So, yeah, I'm going to talk about neuroendocrine tumours, and for some of you this may be a little bit of a slightly out there topic, but I chose this because I've been back in Dunedin now about 2 years, and I spent 4 years working in a neuroendocrine tumour clinic when I was away doing my PhD, which was in stomach cancer, and so I learnt these as a hand-on sort of way of learning rather than learning it from a book. And I know when I was doing my training I always found them really confusing, but I think there are some ways that we can try and make them less confusing. So hopefully if you do see someone who's got one, then you've got a framework to try and figure out what's happening for them. And of course, to make things more confusing, they've just started to change the nomenclature for neuroendocrine tumours again this year. But I think they're making it a bit more sensible. So hopefully by the time we've got the nomenclature in the next version, we might have it nearly right. So neuroendocrine tumours are cancers that arise from cells of the diffuse neuroendocrine system, and the main function of these cells normally is to produce peptides and hormones, and that means that these cancers can sometimes produce peptides and hormones as well. The majority of neuroendocrine tumours form from the bit of the embryo that is the endoderm. This is where I think I should have learnt more embryology when I was at medical school, but I didn't. And the majority of them actually end up coming from the foregut, so the structures that are supplied by the superior mesenteric artery, the celiac artery, but a lot of particularly tumours that occur in younger patients are the appendiceal tumours, so ones that come from the midgut or the SMA. You can also get tumours from other anatomical locations, particularly the ovaries or the testes, but they're less common. But they have a different venous supply, and that can become more important when you think about hormone production and syndromes that they get, because if your tumour has venous supply that bypasses the liver, then those hormones can get into the systemic circulation and people can have hormonal syndromes without having liver metastases. And so that's why some of those weird things can happen. Why are they so confusing? And I think a lot of it is because of the nomenclature that they've had. So we knew about these tumours before Siegfried Obendorfer, which I've probably pronounced completely incorrectly, decided to come up with the name of carcinoid back in 1907. And unfortunately, he described these as really benign lesions. And that's still a trouble that we have now. I have patients that come and see me and tell me, but someone told me that this wasn't a cancer, and yet then they present with metastases later. So all of these are actually cancers. And he figured that out a couple of years later, but the name stuck. So a benign-like tumour, really. In the 1960s, I don't know if you can read that from the back row, sorry.
Front row.
Front row is good then.
Really easy.
We figured out that actually where the tumour arose, depending on its embryonic division, was important, and that could tell you a little bit about what it might do, whether it was going to metastasise, whether it would be associated with carcinoid syndrome, and the types of things it would look like down the microscope, the types of things it would stain with. And when we first came up with a classification for these in the 1980s, we called all of them carcinoid tumours unless they had some adenocarcinoma, and then we just called them mixed, which actually was reasonably sensible, because if you look, we're still calling the mixed ones mixed, we're just changing our acronym really, and that's about it. And so 20 years later, the WHO decided, well, actually, maybe we should look at the differentiation of these tumours and separate them out because they behave differently. And so they came up with well-differentiated neuroendocrine tumours and neuroendocrine carcinomas, and then the poorly differentiated or small cell carcinomas, and that's like your typical small cell lung cancer. In 2010, we did things again slightly differently and split them up into grade 1 and grade 2 neuroendocrine tumours, and anything that was grade 3 was a neuroendocrine carcinoma. That's still what we use for the GI tract, but this year they've separated pancreatic ones out again, going back to that well-differentiated, but now we've got grade 1, grade 2, grade 3, and then the poorly differentiated, which are now small cell and large cell. To get more confusing, lung neuroendocrine tumours are described differently again, and this is where you still get your typical carcinoid, your atypical carcinoid, and then your large cell and your small cell lung neuroendocrine carcinomas. My disclaimer is here, I'm a GI oncologist. I've not treated a lung cancer now for about 7 years, so I don't know anything about these things. Small cell lung cancer is bad. So a summary when you want to think about them histologically is that really they exist on a spectrum. Like many of the things that we do in medicine, we've artificially made these divisions. And so if you think of it more of a spectrum and a spectrum that can change over time, that will help figure out what's actually going on in the patient in front of you. Because of that spectrum, they have differing behaviours, they can produce different hormones, and they have different responses to treatment and different prognoses. All of them, if you want to just lump them all together, call them neuroendocrine neoplasms. If it's well differentiated, then it's a tumour. If it's poorly differentiated, then it's a carcinoma. And that's sort of the simplest way of describing them. So the grade, as well as being described by differentiation, is described by two things when the pathologist looks down the microscope: the mitotic count and also the Ki67. So Ki67 is also an immunohistochemical stain that we use in breast cancer. It stains for a protein that's seen in the cell only in cell division. So anything that's in the G0 or resting phase won't have it in it. Anything that's dividing will show up as being positive. We don't actually know what the protein does, but it's useful for us for doing these sorts of things. Grade 1, this is the GI classification, not the new pancreatic classification. And those of you who are observant might notice one of the issues with this classification in terms of numbers that they've corrected in the pancreatic classification. Anything that's grade 1 has a Ki67 of less than or equal to 2% or a mitotic count of less than 2%. If you've got the Ki67 or the grade that's higher than the other, you always go with the highest. Grade 2 is 3 to 20%, and a grade 3 is anything greater than 30%, anything greater than 20%. So your grade 3s is actually quite a broad range, from something that's 21% positive all the way up to 100% positive. So there is still quite a big variation in behaviour within that group. This is the new pancreatic staging, and really what they've done is gone, well, actually that grade 3 Ki67 of greater than 20% is really broad range, and when we look down the microscope, some of those still look like normal neuroendocrine cells, so they're more well differentiated. So that's going to become a grade 3 neuroendocrine tumour. The ones that look less differentiated and have a Ki67 of greater than 20%, they're all going to be carcinomas, and we're going to divide them on by what they look like. This is a really important thing. So Ki67 staining, the more cells you count, the more accurate it becomes. Counting cells is really tedious. When I worked in Australia, the pathologists don't get reimbursed for doing this stain, and it takes a lot of time. So a lot of people eyeball the stain, and that really doesn't give you an accurate number, and it's not reproducible between pathologists. So counting is really important, but tedious. The pathologists up in Auckland who work in the neuroendocrine MDM, they give us decimal points. That's how many cells they count. They're obviously special people. So if you work a little bit more visually, this is a good way of trying to figure out how to describe these cancers and how they work and what that spectrum is. So all of them are neuroendocrine neoplasms. Anything that is well differentiated is a neuroendocrine tumour, but that encompasses grade 1, 2 and now grade 3 if you're a pancreatic tumour. Anything that, or as you go along the spectrum of differentiation, that's when you're starting to get to that biological behaviour that's more likely to grow fast on serial anatomical imaging. Anything that's poorly differentiated is a carcinoma, and it will have a Ki67 of greater than 20%. So how do these things present? Quite often, the incidental findings when someone's had an appendectomy, or I've got a patient who was being investigated for sarcoidosis, which he did have, but on his HRCT was found to have liver metastases. He was symptomatic from a sarcoid, but not his neuroendocrine tumour. Now he's symptomatic from neither of them, but we treat the neuroendocrine tumour. Particularly one of the lower grade ones, they can still get to really big sizes before we find them, and so they can present with mass effects, so gastric outlet obstruction from a pancreatic mass or even biliary obstruction. You will get the occasional carcinoid syndrome, so that's the symptoms of flushing, diarrhoea, abdominal pain, occasionally wheezing. Sometimes they can have dermatitis as well, and then there's a bunch of other hormonal symptoms that you can get. And these are some of the more common ones, although they're not actually that common. And again, like we figured out back in the 1960s, you can kind of figure out where the primary might be, based on what hormones they're producing, and that's because the cells that these tumours come from are isolated to different organs really. So carcinoid syndrome we think is mainly from serotonin production, but sometimes people with carcinoid syndrome have no evidence of increased serotonin production, so there's probably lots of other hormones that these tumours can produce that we just don't measure. Insulinomas, of course, present with hypoglycemia, and they're pretty much always from the pancreas. Gastrinomas, lots of gastrin, so diarrhoea, peptic ulceration, indigestion, reflux, that's not responsive to normal doses of PPIs. Glucogenomas, I've yet to see necrolytic migratory erythema, so if anyone finds some, please let me know. VOPomas, profuse diarrhea, and again, glucogenomas, VOPomas mainly from the pancreas. Somatostatinomas can present again with diarrhea, steatorrhea and diabetes. And the thing to sort of remember about this when we get on to some of the treatments that we use is these are some of the side effects that we can give people because we use somatostatin analogues. So if someone presents with a syndrome, we can use the hormone that we think is causing that syndrome if it's elevated to follow their treatment response. What are some of the other markers that we can use for neuroendocrine tumours? So the common blood one is chromogranin A. It is present in secretory granules of all neuroendocrine cells, and it's a general marker, particularly on immunohistochemistry, but it's actually a really bad marker when we're looking at it in blood. It can be falsely elevated by all sorts of things. He recently had a referral from someone who had a patient who had previously had sort of moderate risk but non-metastatic, so localised neuroendocrine tumour resected. They got lots of indigestion and so were put on a PPI at about the same time that their chromogranin A was due. Chromogranin A went from normal to above 400, so upper limit of normal was just under 100. Took them off the PPI, waited 3 weeks, repeated it, back down under the normal range. So PPIs can pop those levels up really high, also can go up with chronic atrophic gastritis, renal failure, heart failure. Depends where you get the blood test done because the assays aren't always the same, depends what time of day you get it done. And when they change assays at a lab, if they don't give you a run-in time, the previous blood results that you've had are not comparable to the new ones. And so when you're looking at patterns over years, that can be really frustrating. The other main marker that we use is 5-hydroxyindyl acetic acid, which is a breakdown product of serotonin. So this is the thing that we check in people who have got carcinoid syndrome. Trying to figure out what blood serotonin's doing, I've not yet managed to do, it's just too variable. There is now a spot urine for this, but I also don't know how to interpret that. And the first couple that I got through, they didn't put an upper limit of normal on the results, and so I didn't know what to do with them. Called the lab here, they didn't know what the upper limit of normal was. They finally talked to the people in the lab in Christchurch who were doing the test, and they'd gone, oh, this is a new test. Let's see if we can figure out what makes it change. And so they did urine samples and checked the spot urine, and then they ate food like a banana that had serotonin in it, and one banana put the level from under 50, which is the upper limit of normal, to about 90. So I'm still not too sure what to do with the spot urine yet, so I'm actually making my patients do the full 24-hour collection because I know how to interpret that. But it's a pain to do because you need to avoid a bunch of medications but also be on a low serotonin diet. Most of the literature at the moment says for 3 days before the collection and then the day of the collection that you're on, so that's 4 days. I would actually struggle to go 4 days without eating a tomato. So it can be a little bit frustrating to have to do. So I usually only do this once a year and only in the patients that have carcinoid syndrome. So really there isn't a good test for screening for these, or if you're a bit suspicious about what's going on in a patient in front of you, you can do the tests, but they mightn't actually be helpful for what's going on. So back to what neuroendocrine tumours are. Well-differentiated neuroendocrine tumours have somatostatin receptors on their cell surface. The more you get down that differentiation pathway to the poorly differentiated ones, the less somatostatin receptors you're going to have on your surface, the less like normal neuroendocrine cells they are, and the more rapid proliferation and glucose metabolism they use. And so because of this, we can use these differences to use functional imaging to actually help us manage these tumours really quite well. And this is because we've got somatostatin receptor PET CTs or Octria scans as the cheaper ones. And we can now get the GAT8 PETs in New Zealand, they're just not cheap. and compare them to FDG PET scans, which look at glucose uptake, to then try and get a better idea as to what's actually happening in the patient and the whole patient, not just a little bit of tissue that we get with a biopsy. So example of a patient here who's had FDG and somatostatin receptor PETs done. If you ever look at two PET scans and you're trying to figure out which one's which, the brain uses lots of glucose. So big bright brain means it's FDG PET. You can kind of see the tiny little dot up the top there. So the pituitary sometimes has uptake in a GAD8 scan. So brain, FDG PET, no brain, GAD8 PET. I think this patient has a pancreatic NET, but I can't actually quite remember. The FDG PET is going to show us areas of less differentiated tumour. The GAD8 PET is going to show us areas of more well-differentiated tumour, and if we use them together, we can demonstrate the heterogeneity in the patient. And if you can get both of them done, you can actually use this to sequence treatment when you've got treatments available. But actually what it is like a full body immunohistochemistry test, because you can get a much better idea as to what's happening. So this is a patient that's got an insulinoma, and if we were to biopsy this spot here, which you can see on the GAD8 PET but not the FDG PET, so brain, no brain, then we're going to think that this is a more well-differentiated tumour because we've got uptake on a GAD8 PET but not on the FDG PET. Whereas if we decided that we'd biopsy this lymph node mass and we got that bit there, then this is going to be a poorly differentiated tumour because of that such high uptake with no uptake on the GAD8 PET. And that's going to make a really big difference as to what we want to do for this patient. If I end up treating this bit, and this is what they've got going on, they're going to progress rapidly, and that's really the wrong thing to do. So back to our little summary of neuroendocrine tumours. So well-differentiated neuroendocrine tumours, poorly differentiated neuroendocrine carcinomas, well-differentiated, more slow-growing, poorly differentiated, more fast-growing, functional imaging, well-differentiated, more likely to have uptake on a somatostatin receptor PET-CT, FDG, more likely to show uptake when you've got a poorly differentiated NET. Prognosis, of course, is also related to the, well, we think, I should clarify that, we think prognosis is also going to be related to the functional imaging, but we really don't have that published data yet. So prognosis is actually affected by not only stage in this cancer, like it is with most cancers, but also by grade and by tumour location. What you'll see from these cohorts that we're getting the data for is that actually the evidence that we use to tell us what to do with these tumours is not really what we call gold standard. So most of the cohorts that we look at for epidemiological stuff are retrospective studies because the other studies that have been done are too small to look at this sort of thing. But what you probably don't see too well is that the follow-up that you need is actually quite long. So that says 250 months. My other main focus is upper GI cancers. I like these patients because they live a lot longer. I get to know them a lot better. So in pretty much all subtypes of NETs, so we've got mainly foregut NETs here, pancreatic NETs alone, and then midgut NETs on the far side. Grade 1s do an awful lot better than grade 2 or intermediate grade, and then grade 3s are your carcinomas. But remember, it's that really big range of Ki67s that's included in that grade. So whereas your small cell lung cancer, you would sort of expect to drop off the survival curve here, when you include that whole lot, it's extended out a little bit further. As with every cancer, stage is important. If you've got disseminated disease, you're more likely to do poorly than if you have a very localised disease that we can chop out. And these are really busy. So these are the different primary sites of tumours and survival by those using SEER data. And really the take-home message is if you've got a hindgut tumour, so something that comes from your rectum or the sort of your descending colon type area, you're probably going to do more poorly than if you've got a tumour that comes from somewhere else. Now, because of this long survival, so 250 months on that other graph, NETs are actually not rare. When we look at prevalence, again this is SEER data, and you lump them together, they're actually more common than stomach and pancreatic cancer combined. So there are actually quite a few patients wandering around with these tumours. This is really recent data from the network registry. Before this, we didn't have any data on incidence of NETs in New Zealand because the way that our cancer registry records cancer diagnoses is by anatomical location. And so all of these get tied up in all of the bowel cancers and all of the stomach cancers and all of the pancreatic adenocarcinomas. So the NET registry has two cohorts. One's a whole New Zealand cohort from 2008 through to 2012, and then they've got a longer cohort from all of the diagnoses in the Auckland region. And the incidence, when it's age adjusted, of 6.2 per 100,000 per year in 2012, sits between stomach and pancreatic cancer. So pancreatic cancer in 2012 was about the 7th most common diagnosed cancer in New Zealand, so this is potentially about 8th or 9th. So they're not actually that rare, even though that's always what we've been taught when we lump them all together. But because they're such a heterogeneous bunch, the person that you see now might be very different to the person that you see in 3 or 4 weeks' time. So take-home message, and NETs are diverse, and that means that we've actually got multiple treatment pathways and options, and they depend on where the tumour is, what its grade is, what its stage is, of course, whether it's functional or non-functional, and the symptoms that the patient has. If we had all of the treatments that we could possibly have for these tumours, this is pretty much where we would sit at the moment. But again, it's one of those areas where things are evolving a lot more rapidly than what they have done in the past. So what we're going to talk about now is the treatments that we could use, and then I'll finish by explaining what we've actually got in New Zealand at the moment. And the thing about surgery and debulking and local regional ablative therapy being across the whole spectrum is actually this is one of the tumours where quite often we'll do surgery even in the metastatic setting, because of if you've got a large bulk of liver disease and you're producing hormones, then you can be really symptomatic from that, so chopping some out can help if we don't have any other treatments. And particularly the small intestinal NETs, they can cause lots of fibrosis in your mesentery, and that itself can cause symptoms. So by removing those early on in diagnosis, particularly if it already looks like there's some obstruction to the blood supply to the gut, then we're saving a lot of issues further down the track. So local therapies, talked a little bit about surgery. We do still use external beam radiotherapy, but hopefully in the future that'll be less of a necessity if we do get some other treatments. Liver-directed therapies are used even when we've got treatments, we've got disease that can't be treated outside the liver by that therapy, particularly because it's the tumours in the liver, the metastases in the liver, that end up producing the carcinoid syndrome if you've got one of those mid-gut or foregut NETs or even hindgut NETs, unless it's sort of rectal, because then you've got the venous drainage bypassing the liver again. We can get the first 3 easily in New Zealand. CERT we can't get in New Zealand. Oh, actually, I lie. You can get it in Auckland. In Auckland, it's about $30,000 for treatment. We can get it for about $18,000 in Brisbane, so we usually send our patients to Brisbane at the moment. It's warmer there too. And the guys there are quite nice, and they seem to quite like the little trip. So the systemic therapies that we have, or that there is evidence behind, is these. I'm actually going to start with the second one down because it leads into describing why observation becomes a valid option for some of these patients. So somatostatin analogues. There are 5 types of somatostatin receptors, conveniently named 1 to 5. The 2 somatostatin analogues with evidence behind them are sandostatin and lanreotide. They are both depot injections, and they both have high affinity to somatostatin receptor 2 and 5. There's a new one that's coming through that has affinity to some of the other receptors, but we've yet to see whether that makes a difference to what happens if we use that. The theory is that these analogues bind to the somatostatin receptors and then stop the secretion of hormones and therefore stop symptoms, but there's now also evidence that they delay tumour growth. The 2 trials that have shown this are PROMID, which was the sandostatin LAR trial. Sandostatin is the medication we have in New Zealand. And then Clarinet was the lanreotide trial. Slightly different patient groups, both included functional and non-functional tumours. So when they say functional or non-functional, it doesn't actually mean whether you can see anything in the blood, it's actually whether the patient has symptoms or not. So you may still have elevated 5-HIAA, for example, but actually no symptoms of that, so that would still be a non-functional tumour, so that's more of a symptomatic thing. I suspect that these are not projecting too well. But you can see from the survival curves that we actually get quite you can stick your finger between it, so it's significant by the finger test. But the median progression-free survival in the placebo arm in the PROMID trial was about 6 months, and that was increased to 14 months with the use of sandostatin LAR. Both of these trials you needed to have progression to get into them. So these patients had tumours that had been shown to grow, if that makes sense. In the lanreotide trial, the median progression-free survival in the placebo arm was actually 18 months. So that's quite a long time without any treatment for a cancer. And it hadn't been reached when they got out to 27 months in this trial. We don't have overall survival data, so we haven't been able to demonstrate that this changes overall survival, and they probably won't, and that becomes an issue when you look at our way of funding drugs. So how can we do observation? And that's really because a lot of these tumours have a long time where their tumours don't do very much. And that you can see that in that clarinet with the trial, with the median progression-free survival being 18 months. This becomes really useful when you've got someone who doesn't have any symptoms and is not really wanting to commit to having an injection every 4 weeks for the rest of their life, because that's pretty much what they're committing to. They've got a grade 1 tumour, and they're in their late 70s, they'll probably die with this tumour rather than of it. So they're having they're committing to having that injection every 4 weeks. If you've got demonstrated stable disease on a scan, say for example you're one of the patients who we diagnose with a different type of cancer first, and then you don't behave the way we think you should, then we look back at your histology and go, oh, actually you've got a NET and your tumour hasn't changed, then we've already given you a test, and for you, actually watching for a bit longer mightn't be a bad idea. Or if you've got a bunch of other things happening, you might turn around and say, well, actually, I just want to put this to the side and watch it for a while before we do anything. And they are really valid things to do for lots of people. So for a number of patients, you won't treat them, you'll just watch them. So on to targeted therapies, and somatostatin analogues are actually targeted therapies. And we've got now evidence behind a couple of other targeted therapies having some efficacy in NETs, and that is with everolimus and sunitinib. So everolimus, as you probably know, is an mTOR inhibitor, and mTOR is a protein complex that does lots of good things if you're a cancer. It helps cells grow and proliferate. And if you ever see something called a RADIANT trial and it's cancer related, then it's probably an everolimus trial. And again, unfortunately for the New Zealand setting, we've got evidence of progression-free but not overall survival benefits of using everolimus in pretty much all of our grade 1 and 2 NETs. It doesn't matter where they come from, so pancreatic, lung and GI. So we've got, this is RADIANT 3, that one's RADIANT 4. RADIANT 3 was pancreatic NETs only. RADIANT 4 was lung or GI tract but not pancreatic NETs. They only used well differentiated in RADIANT 4, but moderately differentiated were included in RADIANT 3. These are generally non-functional tumours, so not patients that had carcinoid syndrome or another type of hormonal syndrome. In both cases, you get a 6 to 7 month improvement in progression-free survival. Sunitinib, again, as you'll know, is a multi-targeted tyrosine kinase inhibitor, and again, we've got, sorry, I lied. This is one where we do have evidence of overall survival as well as progression-free survival in pancreatic neuroendocrine tumours. And that's the trial that has demonstrated that. And progression-free survival on the left, overall survival on the right, just pancreatic NETs, but low and intermediate grade, so everything that's not everything that wasn't a carcinoma at the point when they did this. And again, about an improvement, about a 6 month improvement in progression-free survival. And when they published this in 2011, overall survival hadn't been reached, and they haven't published any updated data to actually tell us what the difference in overall survival will be. Chemotherapy. So we actually have multiple agents and regimens that we can use. in any cancer, chemotherapy is more effective if the cells are dividing fast, so that chemotherapy is generally what we would use in the carcinomas, so the higher grade tumours. Definitely first line in the poorly differentiated ones, like small cell lung cancer. We have absolutely no good, solid evidence to guide what we're doing in this setting. None, in fact. This is one of the few times where you would consider using adjuvant treatment in someone who had had a fully resected neuroendocrine neoplasm. And that's because of this sort of retrospective analysis, where if these were esophageal small cell carcinomas, so high-grade neuroendocrine carcinomas of the esophagus would be what we would call them now. And if you did surgery alone, then there was an overall survival of only 5 months. This is a retrospective analysis from a number of years. And if chemotherapy was added, then that prolonged that overall survival to 20 months. And so that's the evidence that we've got as to why we would use it in the adjuvant setting. This is the evidence that we've got in the metastatic setting, and so these are case series. Most of them use cisplatin and etoposide. The response rate in these case series ranges from sort of down around 14% all the way up to 75%. And the survival in months ranges from 6% up to about 2 years. The way that we sort of think about it, particularly the small cell carcinomas of any organ really, is similar to the small cell lung cancer, and this is the small cell lung cancer data. So this trial on the left here is a Japanese trial where they compared what we would normally use, so etoposide and cisplatin, to irinotecan and cisplatin. The trial on the other side is one that used the same 2 combinations. And this is sort of where you wonder whether the way that we metabolise drugs makes a difference to our outcomes, because in the Japanese trial, the irinotecan platinum combination had an improved survival compared to the etoposide platinum combination, but that wasn't seen. So we would normally use carboplatin or cisplatin and irinotecan. There is a quite good registry from I've just got it down there as the Nordic neck. I can't remember exactly what country that comes from, sorry. But this is an analysis of 305 patients who had gastroenteropancreatic nets, so that's the term that we use to encompass pancreatic and GI nets. And they looked retrospectively to see whether adding a third drug in made a difference to survival, because what we've done traditionally is go more is better. And in this case, it looks like no. Retrospective analysis anyway, adding a third drug in doesn't make a difference, and that carboplatin looked the same as cisplatin. So the summary of sort of what we do for the neuroendocrine carcinomas that have advanced disease is that we would really like to give them palliative chemotherapy. These patients, even if they're really sick, we will sometimes treat, because being that they've got a really fast growing tumour, they can have a really quick response. And we can make a significant improvement to their quality of life. And although we're not going to cure them, survival from 1 month going to 1 year makes a really big difference to them and their families. So it's important that we catch them quickly, because sometimes they can get too sick for us to treat them. 3 drugs we don't do because it doesn't seem to improve survival. So that's the non-evidence that we have in first line. The evidence that we have in second line is even worse. And pretty much you can choose your poison and treat people, depending on what side effects they have and what symptoms they've got, and sometimes depending on what their Ki67 is. And if we go back to that Nordic registry trial, they found some quite interesting results, although when you think about them biologically, they become sort of logical, where they separated their tumours by Ki67 in blocks, and the division here where things start changing is around 50 to 60. And when they looked at response rates to chemotherapy, if you had a Ki67 of more than 55%, you had a much greater response. But you had a poorer survival. So if you had a Ki67 of less than 55%, your response rate to the chemotherapy was less, but you survived longer, which suggests, again, that what we've done is lump a bunch of different cancers together. And one of the next iterations, I suspect, of the way that we describe these pathologically will include a different Ki67 cutoff rather than just large cell and small cell, because I've not actually seen good survival data that tells me there's a difference between large cell and small cell. So there are many phase 2 trials of chemotherapy ongoing, so hopefully in the next couple of years I'll know that what I'm doing is actually right. Until then, we just give our best guess. So one of the treatments that you may have heard about in the media is something called peptide receptor radionuclide therapy, or if we're going to use chemotherapy with it, peptide receptor radionuclide chemotherapy. Chemoradiotherapy, sorry. Otherwise it's known as PRRT. And generally when we're being lazy, we don't put the C in if we give chemotherapy. So PRRT may include chemotherapy or not. So what is PRRT? The same peptides that they use for PET scanning, what they do is put a radioisotope onto it. That binds to the somatostatin receptor, that gets internalized into the cell where it releases its radiotherapy. So it's like targeted radiotherapy. They have 3 radionuclides that are used generally. 2 of them at the moment there's no trial evidence behind, but when you think about it again somewhat logically, each of the radionuclides has a different, the particle that it produces, the radioactive particle that it produces has a different length that it travels through. So if you've got lots of really small tumours, you don't really want to have radiotherapy that travels a really long distance, because then you're going to get lots of radiotherapy to bits of tumour that aren't to bits to normal tissue and therefore side effects. So a particle that has a really small path would be better, whereas if you have one really large massive tumour, having a particle that has radiotherapy that travels a longer distance is a better idea. And being able to change that as treatment evolves in a patient actually makes it even more targeted than just targeted radiotherapy. And I just have to use this slide. This is from one of the nuclear medicine physicians that I used to work with. So when we do peptide receptor chemoradionuclide therapy, what we're doing is adding chemotherapy in as a radiosensitizer like we do with lots of other cancers. And we're not yet too sure what we should be adding and where. We think that pancreatic neuroendocrine tumours are more chemo-responsive than GI, so small intestinal neuroendocrine tumours. And so we may use 2 drugs with pancreatic neuroendocrine tumours and 1 drug with small intestinal neuroendocrine tumours, but we still don't know whether we should be doing that or not, and that's subject to clinical trials as we speak. So who can be treated with this? Pretty much you need somatostatin receptors on all of your tumours for them to be targeted. So this is a 38-year-old, metastatic pancreatic neuroendocrine tumour, Ki67 of 15%. They were initially treated, progressive and symptomatic disease, I haven't got what they were treated with, and they had high uptake on their GAT8 PET. Krenning score is the way that they determine uptake on a GAT8 PET, ranges from 1 to 4, and you normally have uptake in your spleen and your liver, and that's what you're comparing it to. So if you've got similar or higher uptake in your tumours compared to your spleen, then you've got a tumour that is definitely suitable for PRRT in terms of somatostatin receptor expression. But does all of the tumour produce or have somatostatin receptors on it? And that's where we need your FDG PET. So brain seen on the one on the right. Yes, you're right. So that's the FDG PET. No brain seen on the one on the left, so that's your GAT8 PET. And kind of eyeballing it looks slightly different. And so that's where you use flash computers to stick it together. And you see actually this patient has that big sort of central mass here that has high FDG uptake, no GAT8 uptake, so PRRT as their first treatment would not be a good idea. You would want to treat them with chemotherapy to treat the FDG avid tumour and then scan them again, because these tumours evolve with the treatment that you have and they may become amenable to being suitable to PRRT with that chemotherapy. So what about this person? This is a 72-year-old who had a pancreatic tail net with hepatic metastases, and they had a Ki67 of 10 to 20%. The pathologist didn't count, they estimated. They had some chemotherapy and progressed. I don't have the FDG PET, but they had concordant disease on it. The way that PRT is given is usually with 4 cycles of induction treatment, sometimes 3 if you have a really good response. So that's the scan, their GAT8 PET scan at their first treatment, and you can see there's a huge amount of disease in their liver. The spot up the top will be where their line goes in. 15 months after, they've had a marked decrease in the amount of avidity on their scan, and their chromogranin A has dropped from 460 back to within the normal limits, so under 100, so normal. 27 months after completion of the induction therapy, they have a restaging scan, and they're found to have progression in their liver metastases, some new skeletal metastases, and so they give them 1 more treatment of lutate, so just 1 dose. And 14 months after that maintenance treatment, they've had further regression of their liver disease and control of their skeletal metastases. So this used to be all the data that we had about this, so just case reports, and the nuclear medicine physicians that I used to work with said that these were more than adequate. So we should be using this in everyone, because a number of the patients that they had treated would have been dead had they not had this treatment. And then the US and North Americans managed to complete this trial, and this was published just this year. And they've used lutetium, so that's the radionuclide that has the medium distance. They've used a fixed dose. The patients that they've put into this trial have been triaged using not GAT8 PET scans, but the same type of SPECT CT that we now have here, so not as accurate. And they've still managed to show a huge improvement in risk of disease progression or death, so it's like an 80% improvement. And it works for all of the subgroups, and so this is now what's considered to be gold standard in many places in the world. So leading on to the New Zealand situation, and if you Google neuroendocrine tumours and put in stuff for the New Zealand Herald, you get a bunch of pictures about people who can't get treatment. Siobhan Conroy is the CEO of the Unicorn Foundation, which is the patient neuroendocrine tumour charity, and she's been working tirelessly to try and improve what we're able to do for patients in New Zealand. So, what can I do? What things can I do for my patients when I diagnose them? I can occasionally get a PET, but I can only get 1 unless they want to fund it themselves. So there's 1 funded indication, and that's if we're going to look at curative surgery and your MRI liver is negative. So I have to do an MRI of your liver, which to me seems like a waste of resources. Southern Cross has a very similar indication, so I can't even get them funded. Their second one, I can get 1 funded through the public system and maybe 1 on their private medical insurance. But for most people, I can't get either. Cost for self-funding, I've got $2,500 a year. The last estimate I saw was about $2,800. Sorry?
For 1 PET.
For 1 PET, yep. And that's probably the same cost for the PSMA PETs that your prostate cancer patients will be asking about as well. Because the GAT8 PETs are done in Auckland, FDG PETs can be done in Christchurch or Auckland. PSMA scans can now be done in Christchurch as well as Auckland as well. What about the drugs? Have 1 somatostatin analogue. They both pretty much work the same, although I have had response or prolonged response in patients who have started relapsing on 1 when you've switched them to the other. The special authority, I can use it if you've got a VIPoma, a gastronoma, an insulinoma, or if you've got carcinoid syndrome and it's refractory to maximal medical therapy. So if you've still got rampant diarrhea despite maximal dose of loperamide, then I can give it to you according to the special authority criteria. So that completely ignores the improvement in progression-free survival and the fact that actually people may have a bunch of symptoms that may not be too bad, but actually severely impact their quality of life, and because of the length of time that these patients need to live with these tumours, it's not inconsequential. Sunitinib's not funded, everolimus is not funded, and both of them about $7,000 for a month. Nearly all of the useful chemotherapy is funded. Streptozotocin is not funded, but it's not actually available, and it's an old chemotherapy that we used to use, but it could still be used as a backup if we had it floating around. Temozolomide is the chemotherapy of choice, really, if you've got a tumour in that Ki67 range of even 10 to 55%. These seem to respond better to this type of chemotherapy than the platinum etoposide chemotherapy. Conveniently, what they've done is said that a metastatic or unresectable, well-differentiated neuroendocrine tumour. So I just need to make sure the pathologist writes the right thing on the path report, and then we can actually get that. PRRT, the chemotherapy is the same as the previous funding, so I can actually give that, but the actual PRRT is not funded and not available in New Zealand. And really, to give it properly, I think you need to have nuclear medicine physicians that know what they're doing, because the tumour's dynamic and it changes with each treatment, and the dose and the radionuclide that you're using, you can modify that to get a better outcome. So maybe not having it at the moment is not a bad thing, and maybe not getting it might be the right thing to do, as long as we can get our patients the treatment somewhere else. The other issue we've got is access to clinical trials. Because we don't have PET scans available, we can't really enrol in any of the cooperative group clinical trials, because they don't have enough money to give you the money to pay for the PET scans. We've also got the issue that although the prevalence might be quite high, it still is a reasonably rare cancer, and we can't shift patients across district health boards to enrol them in clinical trials, which severely limits what we can do. When I worked in Australia, I worked in Melbourne, where I would have patients come from the Northern Territory to come to a clinical trial. And that's one of the things I think we need to start looking at, not just for neuroendocrine tumours, but for cancer patients across the country, that would make it a much more equitable access to clinical trials. What's the cost of PRRT? 4 cycles, I would usually tell someone to expect to spend about 50,000 New Zealand dollars. That includes the cost of your PET scan. PET scan in Melbourne is about $1,000 cheaper than a PET scan in New Zealand. And then you can go to the place where the nuclear medicine physician is. PRRT is also available in Sydney, in Adelaide, and in Brisbane, I believe. So that's the 50 grand is kind of your induction treatment, and then, like the patient that I showed you, you may end up needing further treatment, and so there are additional potential costs as well. And this is the treatment at the moment that a lot of these patients are having to crowdfund. So on that lovely note, I shall leave you with some places that I give patients to get information. So the Unicorn Foundation in Australia started first, and then Unicorn Foundation New Zealand kind of branched out of that. These are patient groups that are really passionate about trying to improve the outcome for themselves and in some cases their family members. There is a patient information booklet that you can download from the New Zealand website. It's very similar to the one on the Australian website. Australian website also has a medical practitioner information booklet, but when you look at it, it's actually very similar to the patient one. EVQ is the website that we print all of our patient information sheets off for chemotherapy, and it's got the information sheets for sandostatin, for everolimus, for sunitinib, for the chemotherapies that we use, but not for peptide receptor radionuclide therapy at the moment. And that's me. So, questions? No?
Listening to it, Sharon, I'm thinking about how difficult this is, because our ordinary patient's health literacy is not that high.
Yeah.
I find this stretches my brain an awful lot, even on a basis of knowing some stuff. And I just wonder about how easy it is for those patients that you've got cancer, but observation alone will be just fine.
I suspect, as probably a lot of you would have figured out if you've got one of these patients, a lot of them have spent many years with weird symptoms before they actually get diagnosed. And so that is actually a good starting point. So this has probably been there for a long time already. If they've got weird symptoms, then what I'm going to do is start them on treatment anyway to try and help with those weird symptoms, so that bit goes to the side. The patients that you're going to put on observation are the ones that have been misdiagnosed before. and then have had a period of observation for that cancer, and that period of observation can sometimes be a couple of years before we go, if you had a pancreatic adenocarcinoma, you should be dead. And then we get someone to look at the tissue again, and then we can say, well, actually your scans have stayed stable, so why don't we just keep scanning you? So it's active surveillance, it's not anything else. Patients with really low volume disease in places where it's not going to cause them any harm. I had a lady in her mid-60s that I met when I first got to Australia who had a medical problem list about this big. And we decided that she had metastatic disease at diagnosis, she wasn't a candidate for surgery, that we would just watch what was happening, because at that point her performance status was about 2, maybe 3. And so she would come in every 3 months. We had scans, so I could do GAT8 PET scans. For the first year we would have done one, for the first couple of years we would have done one every year, and so saw that there wasn't any change. And it's just a matter of talking to them. Sometimes these appointments aren't short, and being open to continuing the discussion, I suppose. And yeah, for a lot of people it's a really challenging idea, particularly when you say to them, no, actually it's cancer, but I'm just going to watch it. And if you're comfortable with that, eventually most patients become comfortable with that. Yes.
We're used to describing it for prostate cancer though.
Exactly. So yeah, similar thing to prostate cancer. Prostate cancer exists on a spectrum. You've got one of the slow-growing cancers that you'll probably die with rather than of. If I treat you, I may give you side effects.
How common is the profound hypoglycemia that you can see with the simvastatin analogues?
Not very common. So what I've seen more frequently is that patients develop diabetes. So they, particularly if they've got some risk factors of having diabetes anyway. So the tests that I do for someone that's on a somatostatin analog is make sure that I do their HbA1c at least sort of every 6 months. And if they do develop diabetes, then it just gets treated the same way as normal diabetes. Other things that can happen is that they can end up with thyroid dysfunction, so I check that too. And they can get gallstones. So I'm trying to get our surgeons, when they go in there to take out their small bowel neuroendocrine tumour, to take out their gallbladder too. Haven't quite got there yet. We'll get there one day.
What's the sort of age spread for NETs? Do you find that you get it in a younger population, or because obviously with prostate cancer it's older people anyway that are...
So that again is a very interesting question. With the network registry, one of the small subsets of patients that we've started looking at is actually the paediatric and adolescent and young adult group, because we don't really know how common they occur. There's very few publications about them, and one of the questions we had is who does the follow-up and what is the follow-up that happens to them, because we don't actually know what it means. And what we've found on a very preliminary look at the cohort is there appears to be 2 peaks. Most of them are appendiceal NETs, so there's sort of the young sort of early to mid-teens who get their appendicitis and are found to have a NET, is what we think. We've not looked into the data yet to see that. And then another peak around their 30s, and then it sort of continues to go around the same level. So not quite the same epidemiology as other cancers, not necessarily a disease of ageing. So that suggests that maybe some of these things sit there and float around for ages, and we're only finding the ones in younger kids because we've taken their appendix out. And if we'd taken their appendix out when they're 80, the same thing might have still been there. Don't know.
And is there any sort of genetic predisposition?
So there's a couple of genetic syndromes, like the multiple endocrine neoplasia. Those families have a predilection to getting neuroendocrine tumours. And those are the ones where it would be really helpful to have the PET scans, because quite often they're going to be more well differentiated, not going to show up on an FDG PET, but you may find multiple lesions on a GAT8 PET when they're first diagnosed with something, and useful for screening them as well.
What's the chance of getting a PET scan here? I mean, are their costs actually coming down all the time on that sort of scan?
Not yet. So the issues with them is not so much the scanners, but the radioisotope and its decay curve. I'm not really a physicist, so half-life. There we go. And at the moment, I don't think we have the capacity to make the radio-labelled tracer for the somatostatin receptor PETs in New Zealand. So they make them in Australia, stick them on an aeroplane, get them here, so they've already lost a couple of half-lives, and then they can do 2 scans in New Zealand. So that is the limiting factor at the moment. So trying to get a scanner down somewhere like Dunedin, where you don't have direct flights in, is just not going to happen because of that. So we're actually better to get our patients to travel and to hopefully get somewhere that we can make those radionuclides and put the scan there. That's what we need to do.
There's coloured pictures of the PET, the 2 different ones, very, very interesting. If they were available when Dr. Brower's wife was thought to have an insulinoma, would they have helped, or is it not so good at getting a negative?
It would have been a really useful test to do. So the GAT8 PET resolution is probably about the same as FDG PET. So once you get something that's less than 1 centimetre in size, or less than half a centimetre in size, it may be too small to be seen. But that's the best test that we've got for localising them. That would have been helpful. A negative one would not have completely ruled it out, but it would have been helpful. It's a very Dunedin question to ask.
He still went to jail, though.
He did, yeah. Okay.
I think I've only, my whole practice, we've probably got 2 neuroendocrine out of about 5,000 patients. I mean, as a GP, you're not going to see a lot of them in your life.
No.
And follow-up is quite difficult, or what tests you do, and you know.
And particularly for the resected ones, if you look
Yes,
at
right.
the guidelines, it's all expert opinion rather than evidence-based. And so it is actually really hard to tell people, and because particularly the slow-growing ones, the chance of the recurrence in the first 5 years is actually really small, whereas with most other cancers, that's when we think about the chance of recurrence. So if you were going to surveil them, maybe you should start surveilling them later, but we don't know that.
You just keep surveilling them. Just enter a recall every 6 months. That's what I do with my one. He just comes to me.
What's the normal path to diagnosis? Because I can't imagine ever picking up one as a GP.
It depends. So quite often, so the incidental findings, that they'll be in hospital for something else, or the pathologist will just find it. We're now starting to get people so the more the radiologists in particular look at CT scans, the more they're finding incidental things, and they're starting to get to know the patterns of what they look like on CT scans. The radiologist who does the Neuroendocrine Tumour MDM in Auckland can even find some of the really small bowel primaries in the small bowel, because of a really subtle change in what the bowel wall looks like, which I think is amazing. I have to go to that MDM on a small screen, so I've never seen a change in a bowel wall that she's pointed out. It may be obvious on the big screen. Patients who present with metastatic disease, it's just a tissue diagnosis. You may have the odd person who comes in with flushing, intermittent diarrhoea, flushing being worse with alcohol or caffeine or chocolate or a big meal. Some of those things might trigger, but quite often if that's a middle-aged woman, you're going to be thinking, okay, well, that's just, what's happening at that time of life. If you ever see someone with proper tricuspid regurg going, carcinoid heart disease. I've only seen a couple walk into clinic because that was what my clinic was, and you can see them in the waiting room and you go, oh, it's their medical student around. But there's not a typical path to diagnosis, and the ones that take a long time because they've had really weird random symptoms, that a lot of them are left with that feeling that they've been made or they feel like that people consider them to be a hypochondriac, and that can be something that takes a long time for them to get over. They always feel that every time they're telling you a symptom that you're going to disbelieve them.
Why are the symptoms like diarrhoea? Why are they intermittent? Why aren't they constant? Why is it just a regular constant
Probably
diarrhoea?
just to do with the release of hormones. So if you have a big meal that can release some more hormones, if you have some alcohol that can release some more hormones, so it's more trigger. There's something that triggers the hormone production that then causes the symptoms. The I've got a couple of patients who have got quite advanced, who we're not treating because they don't want to. And you, every now and then if they come into clinic, you'll see them, and the longer I've watched them, the more they'll flush in clinic, and you can see this sort of flush come over them. And there was a case that was used in one of the physician's exams once that had a neuroendocrine tumour with hepatomegaly, and they had a carcinoid crisis because of all the people examining their abdomen. So I think that's a really rare case. But
managing the symptoms, can be quite challenging, really. And
yes.
I mean, the one I look after, that we look after together, presented today with dyspnea, and she was sure she's a nurse, and she was sure she was in heart failure. She wasn't in heart failure, but she clearly was having dyspnea,
yeah.
and I presume it was neuroendocrine related. And so you're trying, and she has pain as well as so managing her pain, managing her anorexia and her eating problems is quite a challenge, really. So it is multidisciplinary, I think.
Very much, and it would be nice to be able to give that patient some octreotide.
Yes, that's why I asked you about how common the hypoglycemia was.
Yes.
Because that's why she didn't.
No, I don't think she's had hypoglycemia from her injections. So this is another interesting. This is a patient who was given a whacking dose of lanreotide when she was first ever started on somatostatin analogues, and you can get side effects from them. So if I'm starting someone on one of those long-acting injections, like once you put it in there, it's there for 4 weeks. I give them some test doses, and occasionally, very occasionally, you'll have a patient that does get quite significant symptoms from their injection. And then you've got those short-acting octreotide injections, which was all we used to have, and so then you can slowly titrate them up. If a patient who didn't want to have the long-acting octreotide injections did want to have something for immediate symptomatic relief, then short-acting octreotide would actually be an option, but again, that wasn't something that this person wanted to try. And I have the occasional patient who has boxes of short-acting octreotide at home in the fridge, so when they have breakthrough symptoms near the end of when they're, so coming up to their next injection, they've got something that they can give themselves if they need to. Because I don't have anything else I can give them. I can't give them PRT, they can't afford it.
Thank you.
Hopefully it was useful.